Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 2 of 3 on eye disorders causing diplopia or double vision in this chapter. In this set of slides, we will discuss 5 etiologies, namely supranuclear disorders of gaze, horizontal gaze, internuclear ophthalmoplegia, vertical gaze, and Parinaud syndrome. Supranuclear disorders of gaze are often mistaken for multiple ocular motor nerve palsies. For example, Wernicke's encephalopathy can produce nystagmus and the partial deficit of horizontal and vertical gaze that mimics a combined abducens and oculomotor nerve palsy. The disorder occurs in patients who are malnourished, alcoholic, or following bariatric surgery and can be reversed by thiamine. Disorders of vertical gaze, especially downward saccades, are an early feature of progressive supranuclear palsy. Smooth pursuit is affected later in the course of the disease. Parkinson's disease, Huntington's disease, and olivo-pontocerebellar degeneration also can affect vertical gaze. After hemispheric stroke, the eyes usually deviate toward the lesioned side because of the unopposed action of the frontal eye field in the normal hemisphere. Seizures generally have the opposite effect. The eyes deviate conjugately away from the irritative focus. Parietal lesions disrupt smooth pursuit of targets moving toward the side of the lesion. Bilateral parietal lesions produce Balint syndrome, which is characterized by impaired eye-hand coordination, difficulty initiating voluntary eye movements, and visuospatial disorientation. Descending cortical inputs mediating horizontal gaze ultimately converge at the level of the pons. Neurons in the paramedian pontine reticular formation are responsible for controlling conjugate gaze toward the same side. They project directly to the ipsilateral abducens nucleus. A lesion of either the paramedian pontine reticular formation or the abducens nucleus causes an ipsilateral conjugate palsy. Lesions at either locus produce nearly identical clinical syndromes, with the following exception. Vestibular stimulation through the oculocephalic maneuver or caloric irrigation will succeed in driving the eyes conjugately to the side in a patient with a lesion of the paramedian pontine reticular formation, but not in a patient with a lesion of the abducens nucleus. Internuclear ophthalmoplegia results from damage to the medial longitudinal fasciculus, ascending from the abducens nucleus in the pons to the oculomotor nucleus in the midbrain. Damage to fibers carrying the conjugate signal from abducens interneurons to the contralateral medial rectus motor neurons results in a failure of adduction on attempted lateral gaze. A patient with bilateral injury to the medial longitudinal fasciculus will have bilateral internuclear ophthalmoplegia. Multiple sclerosis is the most common cause, although tumor, stroke, trauma, or any brainstem process may be responsible. 1.5 syndrome is due to a lesion of the medial longitudinal fasciculus combined with a lesion of either the abducens nucleus or the paramedian pontine reticular formation on the same side. The patient's only horizontal eye movement is abduction of the eye on the other side. Vertical gaze is controlled at the level of the midbrain. The neuronal circuits affected in disorders of vertical gaze are not fully elucidated, but lesions of the rostral interstitial nucleus of the medial longitudinal fasciculus and the interstitial nucleus of Cajal cause supranuclear paresis of upgaze, downgaze, or all vertical eye movements. Distal basilar artery ischemia is the most common etiology. Skew deviation refers to a vertical misalignment of the eyes, usually constant in all positions of the gaze. The finding has poor localizing value because skew deviation has been reported after lesions in widespread regions of the brainstem and cerebellum. Parinaud syndrome is also known as dorsal midbrain syndrome. This is a distinct supranuclear vertical gaze disorder caused by damage to the posterior commissure. It is a classic sign of hydrocephalus from aqueductal stenosis. Pineal region or midbrain tumors, cysticercosis, and stroke also cause Parinaud syndrome. Features include loss of upgaze and sometimes downgaze, convergence retraction nystagmus on an attempted upgaze, downward ocular deviation known as the setting sun sign, lid retraction known as the Collier's sign, skew deviation, pseudo-abducens palsy, and light near dissociation of the pupils. This ends part 2 of eye disorders causing double vision or diplopia. Next set of slides will deal with 6 more eye disorders that cause double vision or diplopia.